My name is Sarah Tabor. I'm one of the pediatric rheumatology attendings at the Hospital for Special Surgery. And pediatric rheumatology is a small subset of rheumatology in general. It's a very small specialty. There are only about 300 of us in the country who do it. And we see kids who have autoimmune and autoinflammatory disorders. A lot of what we see are children who nobody knows what's going on with. So we get a lot of referrals from general pediatricians saying, could you help us figure out what's happening here? A lot of kids who've had fevers, joint pains, symptoms like that for years and have never been diagnosed. That's pretty common for us. And so pediatric rheumatologists typically see patients starting at infancy up till the age of about 18 to 21. And it sort of varies as per pediatric rheumatologist how far we'll see. And at that point, we look to transition them to adult care, which can be a process because sometimes they get very attached to us. But we sort of will do it in conjunction with the adult rheumatologist, maybe over the course of a few sessions, and try to get them established so that they'll continue following through. Because a lot of these diseases that we see are chronic diseases, so they're diseases that people will have for life. We use a lot of different treatments in these kids, ranging from something as simple as an NSAID, could even be Motrin, all the way up through and including chemotherapy. So I started a research project in my fellowship actually looking at localized scleroderma, which is a rare disease that we see in pediatric rheumatology. It can be seen in adult rheumatology too, but much more common in children. And localized scleroderma is a type of scleroderma that predominantly affects kids. And instead of having involvement of the whole body and the organ systems, they'll only be part of the body affected. So a part of the face, maybe one limb, maybe it'll just be a stripe on the back. When children have localized scleroderma, it tends to follow certain patterns called Blaschko lines. And these patterns correlate with the migration of embryonal stem cells. There are a number of skin diseases which follow these Blaschko lines, and they're typically thought of as being the result of somatic mosaicism, or a mutation that happens later, so not in the sperm or the egg, but when you're a developing ball of cells. And so what we're looking at is 10 patients with localized scleroderma, and we're doing skin biopsies from affected and unaffected skin, and looking at genetic changes which are present just in the affected skin in these patients. And we're trying to basically find genetic targets for what's causing this disease, which is poorly understood at the moment. So pediatric rheumatology really is a very small field in medicine, and not that many people go into it. It's hard to generate interest because a lot of people in pediatric residency might see maybe 1 or 2 cases of children with these diseases. A lot of hospitals don't have attending pediatric rheumatologists on staff. For me, what first sparked my interest was actually that I was diagnosed with spondyloarthropathy as a teenager and was treated by a pediatric rheumatologist who later went on to become my mentor and my boss. I think pediatric rheumatology is a very exciting field in that there's a lot of research and it's moving very quickly. A lot of the medications that we use, in fact almost all of them, were approved in adults first, and some of them are still only actually approved in adults, and we have to adapt their use to the pediatric population. So as the specialty grows, we're really seeing a lot of developments in terms of drugs which are being studied in the pediatric population and understood for their effects in children as well.